Welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/follow. In the show, we have Ira Memaj. She's a public health educator, and she co-wrote the Kevin MD article, The Local and Global Concerns of COVID-19. Ira, welcome to the show.
Thank you for having me. I appreciate it.
We'll get into your article in a little bit. First off, just briefly share your story and journey to where you are today.
Yeah, absolutely. So my public health journey started in Detroit, Michigan, because that's where I grew up and went to school. And originally I wanted to do medicine after getting many research opportunities that I was very fortunate about and seeing the social conditions in Detroit and mainly working with community-based organizations. So it was the community engagement that really sparked my interest in public health and wanting to analyze how social constructs, policies, and laws history really has shaped the conditions that people live in and ultimately how that impacts the health of populations. And that's when I decided to pursue public health. I got my master's in public health and then decided to get my PhD in public health as well. And that's where I am right now. I'm currently based in New York.
All right. So give us an example. Tell us a story of something that you've done in the past from a public health standpoint that really impacted the community, moved the needle in the community that you worked at.
Yeah, I think one of the major events, so to say, or experiences that shaped the trajectory of my career was sometime during my undergraduate years. I was talking with one of my mentors, Dr. Latoya Falk, and we were talking about incarceration rates in Detroit and the prison conditions. And we decided to start collecting books and donating them to correctional facilities. And so we started this little project, but over the months, as time went by, we started getting letters from incarcerated folks, the librarian in correctional facilities that we were working with, to expand the project even more. So we started to furnish their libraries with GED books and host also like community panels to talk about mass incarceration in general and what the community was doing. And so I think that was like the experience that had taught me a lot about the history, how things came to be, so to say, and again, the laws and policies that impact people and their well-being, and what we can do to come up with some solutions that can improve the well-being of those individuals. And obviously it's more of a transformational change. And I understand that these are incremental changes that we make. However, even those little victories should be recognized and celebrated. And I think one of the main things that I've learned in the field of public health is the power of the collective community, because sometimes when we look at history and when we really examine what really is going on, like the root problems, we tend to feel despair. And I don't blame people for feeling that way. However, sometimes despair kind of hinders our actions. Mm-hmm. And so I think it's important to keep in mind the power of the collective community, to work with community-based organizations and to center the community that really is feeling the burden of certain conditions and diseases.
All right. And we're going to talk more about the power of the collective in your Kevin MD article that you co-wrote. It's titled The Local and Global Concerns of COVID-19. Now, for those of you who get a chance to read your article, just walk my audience through it and share the story of why you decided to write it.
Yeah, so this article was written by one of my mentors and I, Dr. Robert Fuller-Love. And together we worked a lot during COVID-19, as a lot of public health officials were as well. But one thing that we wanted to talk about was that at the time, it was the rise of vaccines became available and a lot of people were feeling hopeful. And sometimes we get lost because we apply whatever is going on to the standard, so to say, and that comes from ideologies that are so much embedded in our society in America, that we think that because vaccines are available to everyone, that means that everyone has access to it, when in reality, that's not really the case. And we wanted to look into what was happening in US and also some of the countries globally speaking, so to say. And obviously we couldn't mention all the countries, but we spoke a little bit about India and then the dire conditions that were happening and are still happening in Yemen, just to show that the frailties of public health infrastructure and how important it is to invest invest in public health infrastructure, that future pandemics, because they are bound to happen, especially with climate change, we can be better prepared so more people are not impacted at such a larger scale.
From a public health lens, how was the collective response to COVID in the United States?
I do think that obviously we could have done so much better because our response was not as timely and it was very much downplayed. So we tend to have this, again, because of these individualistic ideology, determinism, economism, and like the American creed, as Dr. Geronimus and Thompson have stated in the past for public health officials, we tend to neglect a lot of equity in our responses. And so that ignores very important populations that historically have been marginalized. And when we do come up with these life-saving technologies like treatments and vaccines, those communities that have been exploited and have had this history of abuse are very mistrusting of the medical community, rightly.
So, give us an example of some of those populations that were marginalized during the COVID response.
Yeah, I'll talk a little bit about my work. So during end of 2020 to 2021, I went back to Detroit to work with DABA, which is the Detroit Association of Black Organization, headed by Reverend Horace Sheffield. And we worked with community-based organizations, any hesitancy and concerns that people in Detroit, neighborhoods that have been historically marginalized, which were poor Black and Brown neighborhoods. And so we partnered with Quest Diagnosis to make sure that people had access to vaccines, but while also having access to these vaccines, we were also there, professionals, health professionals, trusted leaders in the community were there to ensure people understood what the vaccine was about, to address the concerns, and why it was important to get vaccinated. Other topics that I have covered along with my mentor, Dr. Fully Love, has been our response to incarcerated populations. Usually, almost all the time, any kind of response that we have to public health emergencies, we tend to ignore incarcerated populations. And that's not right, because the state of being incarcerated in and of itself already presents a lot of health issues, the overcrowding, the poor ventilation, but also prison populations have also been very vulnerable to abuse in medicine, where they have been used as participants in studies without their permission. And when we have something like, here's the vaccine and here you take it because you have to, without really being culturally competent or also taking accountability where public health, medicine, and even public leaders have gone wrong, that presents a lot of issues, because here you have this life-saving technology that can save someone's life and prevent transmission, but yet there is this mistrust. How do you navigate that? And I think that's where we failed in communicating, taking accountability, and really shaping policies that abandon our individualism-like ideologies.
Now, can you contrast the collective action to COVID in the United States? And you said that you did compare it with other countries. So, talk about that contrast between the collective action in the United States versus those of other countries.
Yeah, so I think the best example that comes to mind, especially globally, is Rwanda. After the genocide in the 1990s, Rwanda was left to repair a lot of their infrastructure, and they focused a lot on their public health infrastructure. And one of their main focus was community engagement and centering community workers and really using them to build trust with their community and make sure that the communities had access to treatments, screenings, and healthcare access, talking with their doctors and whatnot. And during COVID-19, they actually set up this really interesting way of testing people and providing treatment, where they worked with doctors and healthcare workers and community workers, where they communicated with each other in order to have those health providers go and visit people in their homes, because sometimes not everybody has access to and the means to go to the hospital and whatnot. So it was very community and centering this collective approach, so to say, in how they tested people and provided treatment. And while here it was more wear masks and keep your social distancing and whatnot, without considering that not everybody has those choices. So in United States, because there is this American creed ideology and individualism, so to say, we expect people to do what we say without understanding that this is really a regime of choices and not really giving people the opportunity or understanding that some folks do not even have the luxury of making the choices that we're forcing them to make. For example, many low income people, immigrants, Black and Brown communities are essential frontline workers that could not really escape, so to say, from like social distancing and whatnot. Or even in prisons that we talked about, how do you do social distancing when you're so overcrowded in
Mhm.
space that you're so confined in? It didn't take until perhaps like vaccinations when we started to really utilize our partnerships with community-based organizations and faith-based organizations to ensure that people had access to the vaccine and address vaccine hesitancy. But then again, that didn't happen in every state either. Because of this individualistic ideology, every state has their own rules and policies, which also creates a lot of disparities, whether it's in data, whether it's in outcomes eventually.
So you alluded to this several times about the uniquely American individualistic quality. So going forward, what are some of your solutions in terms of squaring that history of individualism with the collective action that public health normally needs? How do you square those two sides?
Yeah, and that's a challenge, right? Because you have public health that is all about preventing disease and putting people first, which really it's all about like this collective look, ecological look, right? Where everybody is responsible for everyone's well-being. And then you have these ideologies that are so much embedded in our country, like individualism, the American creed, where it's all about meritocracy, right? Where if you work hard and if you follow the rules, you'll succeed, so to say. And if you don't, that then it's your fault. And so that when that kind of ideology is applied to health, we start to victim blame when we say people are sick and that's because of their fault and not because of social structures that have really shaped the types of laws and policies. For example, redlining, gerrymandering, the food apartheid settings and whatnot, that really have contributed to people having these pre-existing conditions and make them a lot more vulnerable to, for example, COVID-19, or perhaps even future public health emergencies that will emerge.
We're talking to Ira Memaj. She's a public health educator. We're talking about her Kevin MD article that she co-wrote titled The Local and Global Concerns of COVID-19. Ira, what are some of your take-home messages that you want to leave with the Kevin MD audience?
Yeah, I think, and I know this probably sounds a little woo to people, but I am a firm believer in the power of the collective effort. And I think the one thing that we need to do is really gather up our courage, collective courage, to go against the grain and truly look into reimagining the world, a different kind of world that is more just, more equitable, and a lot more healthier. And start with that. And also to keep in mind that the journey for transformative change that we are seeking, right, systemic change, it will take a while and it's a slow journey. But I do think that making these incremental changes, even though they may seem small and sometimes still think that it's not enough, they should be celebrated and used as stepping stones for that kind of legacy to continue, right? To do good and to create that world that we do imagine.
Ira, thank you so much for sharing your time and insight. Thanks again for being on the show.
Thank you.